means problems with the right side of the heart. So the classic cardiac indication associated with cardiorespiratory failure would be pulmonary embolism. The other aspect of it is when you've got severe pulmonary disease or pulmonary hypertension from various causes that are usually related to congenital heart disease, that you may get right heart failure as well. But most of the cardiac failure that the cardiac surgeon and cardiologists deal with isn't actually right heart failure, it's left heart failure. And in those situations you may need support for preoperative stabilization. You may need to buy time so you can do investigations, and there are times when you get even further out of the game, and it's actually you need to put the patients on when they're being resuscitated. This is called ECPR. Of course, there's the one that we all get depressed about, which is the post-operative support. Usually post-operative support in the presence of modern cardiac surgical techniques means some degree of intraoperative failure. More importantly, in the countries like the UK and the USA, ECMO is being used quite extensively to either bridge to transplant directly, or more usually now to bridge to some form of device like a VAD or total artificial heart, or as we mentioned earlier, bridge to recovery. Now it's actually fairly difficult to say what are the indications and what are the numbers you should use to decide when to use ECMO in the cardiac failure group. Obviously, if you're using all the inotropes and all the maximal therapy that you can think of and you're failing, but you still think you have a reversible problem, then that would be an indication. Inability to wean from cardiopulmonary bypass, which is usually the situation in the children's group rather than the adult group, then that again would be an indication, fairly clear cut. Cardiac arrest is another fairly clear cut one. Pre-op stabilization is a difficult one. Most patients you can get to the cath lab or to the echo lab without ECMO, so deciding what numbers you would do this for is really not appropriate. It's really a case-by-case assessment. Dysrhythmia we've mentioned. It's very good for supporting arrhythmic patients. You can usually treat arrhythmias either pharmacologically or electrically or both. Bridge to transplant we mentioned. Now in terms of contraindications, this might seem a bit crazy when you're saying you put patients on in cardiac arrest, but in terms of the patients who are post-cardiac surgery in the ICU, you need to decide either you're going to use ECMO or that you're not going to use ECMO in a particular case. There's no good leaving the patient languishing for hours and hours and then decide when they're almost dead that you're going to do ECMO. That is not the way to do it. So the relative contraindications are prolonged periods of shock, prolonged periods of oliguria, and so on. So